obesity. After diet, exercise is the most important thing. Any kind of physical activity may reduce your risk of developing colon cancer. What a great thing. That you should not have carcinoma of the colon, you can avoid it to a great extent. And often curable disease in situ or in more than the situ, it is localized to the bowel alone, not going to the lymphatics or not going to the distant metastasis, then chances of the cure will be very, very high. Surgery is the primary form of treatment. Surgery is the primary form of treatment and results in cure in approximately 50% of the patients. This is all, whether localized or metastatized to the distant places or even to the lymphatics. The overall chance of survival is 50%. Now the question is recurrence following surgery. If surgery is done and there is recurrence of the cancer, it is a major problem and is often the ultimate cause of death. So that recurrence, if it happens, naturally, it will happen to those groups who are not avoiding such things as you have seen, the diet and the exercise, all these things. Prognosis. What is the prognosis? So here it differs. For colon cancer, the overall 5-year survival rate for people is 64%. This is overall rate. Okay, now we go step by step. If the cancer is diagnosed at a localized stage, when the tumor was localized to the bowel, it was not metastasized or not gone to the lymphatics, the survival rate is 91%. So this 5-year survival rate, instead of 64%, it will become 91%. If the cancer has spread to the surrounding tissues of the bowel or organs and or the regional lymph nodes. So you are seeing and or to the regional lymph nodes. The 5-year survival rate will become from 91%, it will go to 72%. Okay. But if the colon cancer is spread to the distant parts of the body, the 5-year survival rate will be will be only 14%. So once it goes to the distant parts of the body, you can see the 5-year survival rate. That is terrible. So we must be very particular about all these things. Now come to the rectal. That was the colon cancer, rectal cancer. Why we are talking about the rectal cancer? Since colorectal cancer, that cancer in the lower part of the colon and the upper part of the rectum, is very common. So for rectal cancer, the overall 5-year survival rate for people is 67%. If the cancer is diagnosed at a localized stage, the survival rate is 90%. If the cancer has spread to the surrounding tissues or organs or the lymph nodes, the 5-year survival rate will become 73%. But if the cancer has spread to distant parts of the body, the 5-year survival rate is 17. So more or less, both the rectal cancer as well as carcinoma of the colon, they follow the same prognosis, more or 2-3% this side or that side, but overall it is the same thing. Medical conditions that increase the chances of colon cancer. So the risk factors or risk medical factors. First is the inflammatory bowel disease. In short, we say it IBD. IBD. People who have conditions like chronic ulcerative colitis and Crohn's disease or Crohn's colitis, which cause inflammation in their colon lining, that is mucosa, may have an increased risk of colon cancer. So you are seeing the chronic inflammatory bowel disease going for years together, there is more chance of developing carcinoma of the colon. The risk increases if you have inflammatory bowel disease that lasts more than 7 years and affects large parts of your colon. So two factors are there. One is the duration and another is the extent of inflammation. So if inflammation affects the large parts of the colon, more chance of developing carcinoma is there. Then some inherited conditions are there. Certain conditions like Lynch syndrome and familial adenomatous polyposis, they increase risk of developing colon cancer. So these inherited conditions are there which increases the chance of colon cancer. Colon cancer may happen if one inherits a gene that causes cancer. In the beginning, I have told you about this gene. So that was the genetic fact. A family history of colon and other kinds of cancer. Sometimes what happens, this gene is inherited, but fortunately, it comes just after the birth of the child. Okay, so it is not coming from the parents, not coming from the, so it comes only after the birth of the child, and then when the person becomes adult, it can cause development of the carcinoma of the colon. A family history of colon and other kinds of cancer, if a close family member has colon cancer, you have an increased risk of developing the condition. Naturally, the family history is important, as you all know. Close family members include your biological parents, siblings, and children. Okay? So, if they have got any history of carcinoma of the colon or any other carcinoma also, then we have got more chance of developing cancer colon. Risk may be higher if any biological family member developed colon cancer before the age of 41. Naturally, this cancer, as you know, usually occurs after the age of 50. Usually after 50, colon cancer is seen. But if any in the family, it has affected any person who are biologically related to us before the age of 45, then our chance of developing colon cancer becomes more. If your parent, sibling, or child has an advanced polyp, you may have an increased risk of colon cancer. So this word again, you will have to see advanced polyp. What is advanced polyp? So we will come to that. What is advanced polyp? Multiple polyps. People with numerous colon polyps, not single, but multiple polyps, including adenomas, serrated polyps, or other types of polyps. They often have an increased risk of developing polyps and colon cancer. So even adenomas becomes polyps and colon cancer. People may inherit a tendency towards having many colon polyps. So this is again inherited thing. If it is in the, it may come to the person also. May, not always. Now, what is this? An advanced polyp. I talked earlier. First, it may be a large polyp, but only becoming large is not an advanced. Advanced polyp may be a large polyp, and medical pathologists may characterize a polyp as being advanced if they see certain changes in the polyp when they look at it under a microscope, which are signs that the polyp may contain cancerous cells. Okay, so the advanced polyp, we will say only if the pathologist give the report that it is containing some cells which simulate cancerous cells. Then only we say it advanced polyp. Okay. Now the common symptoms of colon cancer. The first is the blood in your stool. The Americans say it poop. Other things from hemorrhoids to anal tears to eating beets may change your poop's appearance. So these are the things you will have to be particular that blood in the stool does not mean the patient has got carcinoma of the colon. The more other conditions where you can find blood, commonest is hemorrhoids depending upon the age of the patient, anal tears may be there, and sometimes even eating beets. If you eat beet, there will be no bleeding, but it will change the color of the stool, and the patient may think that there is blood coming in the stool. So you will have to take the history if patient has taken any beets or not. But it is always better to check with a healthcare provider anytime if one notices blood in or on the stool. So naturally, you will have to consult the person when you are going to the public field and to make them aware. If you are posted in some health post, some primary rural center, primary health center, then it is one of your duties is to make the patient aware of certain things which can be prevented, which are preventable to a certain extent, not 100%, but to a certain extent. So you will have to tell. So as far as carcinoma of the colon is concerned, you will have to tell them, if you see blood in the stool, you must come to us. You must come to some doctor and get it confirmed from where the blood is coming. Persistent changes in your bowel habits, how you poop, how you pass the stool. Talk to a healthcare provider if you have persistent constipation. If chronic constipation is there, you should go and meet your doctor. And or persistent diarrhea, either persistent constipation or persistent diarrhea. Or if you still need to poop after going to the bathroom, if you're going for passing stool, coming back and you still feel, you will have to again go for passing stool. Then this type of thing happens, then you think there is something wrong and you should go and meet the doctor, okay, of the area. Here one more thing is there, sometimes constipation and diarrhea, it is come in sequence. First constipation, then diarrhea, then again constipation, then again diarrhea. So it may be of any type of thing, either constipation only, chronic constipation, or chronic diarrhea, or constipation followed by diarrhea. Okay. Next thing will be abdominal pain. In layman term, we say belly pain. Belly pain with no known cause. That does not go away or hurts a lot. So if chronic type of pain is there, always some patient is feeling discomfort, it may not be very acute. Then also the patient must be cautious and go to the doctor to tell about this chronic abdominal pain. Many things may cause, as you know, many things may cause belly pain or abdominal pain, but it is always best to check with a healthcare provider, means doctor, if you have unusual or frequent belly pain, abdominal pain. And next is the bloated stomach. Like belly pain, there are many things that may make you feel bloated. Always you will have to have you will feel there is distension of the abdomen, and even after passing the stool, you feel still it is distended. So that feeling is there. So if you have got like that, it is better to go and get it checked by the doctor. Otherwise, talk to a healthcare provider. If bloated belly lasts for more than a week, if it is okay in 2 to 3 days, no problem. But if it continues for a week or more, then you must go to the doctor. And even if it gets worse or have other symptoms like vomiting or blood in or on the poop, so either it is persisting for more than 7 days, or bloating may be there with other symptoms like vomiting or passing blood in the stool, then you must go to the doctor. Next is unexplained weight loss. There is no reason why I am losing my weight. Why I am losing my weight. This is a noticeable drop in the body weight when patient is not trying to lose weight. That means patient is not fasting, patient is not trying to lose his weight by his own, but still there is loss of weight, and other people always ask, what has happened to you? You are looking so thin. Are you doing fasting or anything like that? Then you have no answer because you are not doing anything. So it is usually seen in right colon cancer. Unexplained weight loss is usually seen in right colon cancer. Right, I have already told you the ascending colon, hepatic flexure, and proximal 2/3 of the transverse colon, which have been developed from the midgut. Then vomiting may be there. Talk to a healthcare provider. If vomiting periodically means after 3 days, after 4 days, for no known reason, or if vomiting a lot in 24 hours. So both types of vomiting may be there. If you are persistently vomiting for 24 hours, immediately go to the doctor. Or if you are vomiting after 2 days, after 3 days, and it is going like that, you should go and see the doctor. Fatigue and feeling short of breath. So what are these points I am telling you? So you will have to take the history of the patient on these grounds. So on these grounds, you will have to take the history of the patient. Fatigue and feeling short of breath. Patient becomes immediately tired if going up or if going on a long drive, or not drive, long walking. Patient is in between feeling fatigue, and there is breathlessness. These are symptoms of anemia. Unexplained anemia may be a sign of colon cancer seen commonly in right colon. So cancer of the right colon, sometimes the patient presents with only vague things, fatigue, feeling short of breath. You are examining, you are seeing patient is too much anemic. But when you are going for different tests, you are not finding any cause of anemia, any cause of weakness, or any cause of shortness of the breath. So if you are not finding, then keep in mind there may be carcinoma colon, and you will have to diagnose on that basis. But you should keep in mind that unexplained weight loss, unexplained fatigue, and feeling of shortness of breath, and anemia, features of carcinoma of the right colon. Then here only in overview I am telling you, latest treatment. Somebody asked, what is the latest treatment in advanced cases of carcinoma of the colon? These two drugs are there, which had come in the market. Cetuximab and panitumumab. These are available on the National Health Service of England for advanced bowel cancer. They are using it for advanced with other drugs of the chemotherapy for the first time also, not waiting that it should be used in the last if no drug is giving relief to the patient. It is not like that. One of them may be used in the first lot only, along with other drugs of chemotherapy. Here there is a catch. If your bowel cancer cells have a normal RAS gene, then only these two drugs will help you. If RAS gene or RAS proteins, these are important for normal development. But if they become active, if RAS gene is normally present in the body and they are important for normal development, but if these genes, RAS genes, become active, then it drives the growth, proliferation, and migration of cells, and in such cases, these drugs may not be so beneficial. So first you will have to, by investigation, know whether RAS gene is normal or active. If normal, you can give these latest drugs. Okay, I think you understood this. Now, this was the overview of the carcinoma of the colon. I may take a few more minutes to give you one, just to make it more clear to you. We will show you the other slides too. Now, as you are seeing here, carcinoma of the colon is the tumors of the colon, which may be benign or malignant. If it is malignant, then it is known as carcinoma of the colon. Adenocarcinoma is the most common carcinoma of the colon, and it arises from the columnar epithelium. That is its origin. Oh, sorry. Wait. You can see the target points of cancer in the colon. Ascending colon, you are seeing 5%, hepatic flexure 2%, transverse colon 5.5%, splenic flexure 3%, descending colon 4%, sigmoid colon 21%, and rectum 38%. Okay, so maximum chances of carcinoma of the colon lies where? In the sigmoid colon. So if it is colorectal cancer, that is part of the lower part of the sigmoid colon and upper part of the rectum, that is the commonest cancer in the colon and rectum, colorectal cancer. Okay, so this is the distribution of the colorectal cancer. The gross types of carcinoma of the colon, especially in the left side, left colon, is annular, tubular, ulcerative type, and cauliflower type. These are the gross types that you can see by your own eyes, macroscopic, not microscopic, macroscopic. So you can see it. Annular, tubular, ulcerative, and cauliflower. You can see it, annular, tubular, ulcerative, and cauliflower type. So these are the types which you may get it. Exactly etiology is not known. There are certain pre-malignant conditions which later on may develop into cancer. That is, I have already told you all these things: familial polyposis, ulcerative colitis, adenoma carcinoma sequence. Some of you wanted to know. Carcinoma develops in familial polyposis coli patients after the age of 20 years. familiar polyposis coli patients after the age of 20 years. Overall risk in ulcerative colitis is 3.5%. Overall risk of ulcerative colitis become malignant is 3.5%. Local spread and adjacent to the local spread to the adjacent structures. So the adjacent structure to the colon may be affected by locally spreading of the tumor. Then lymphatic spread, N1, N2, N3. N1, node 1, immediate vicinity. The lymph nodes lying in the immediate vicinity of the colon, if they are affected, it is N1. N2, if the vessels supplying the arteries supplying the colon, if the lymphatics along the vessels, they are affected, then it is known as N2. And if it is along the superior and inferior mesenteric arteries, then it is known as N3. If it is spread through the blood, then it goes to the liver through the portal vein. It goes to the liver. Liver is the commonest distant organ where metastasis may occur. Then there is staging, because the treatment also depends upon staging. What type of treatment we want to know, we want to do, whether we want to do curative treatment or palliative treatment. That will depend upon the Duke's staging. Stage A, stage B, stage C, and stage D. Tumor not invading mucosa, only it is in the mucosa itself. It is not going to the submucosa, not invading it. Tumor invading muscle layer. If it has gone up to the muscle layer, stage B. C, tumor affecting regional lymph nodes. And stage D, of course, metastasizing to distant organs. So this is about the staging. Here it is the diagrammatical of the Duke's staging. Clinical features seen after 50 years, as I told you, but it can also occur in a younger age, especially if it is genetic. Bleeding per rectum and constipation. However, symptoms vary. Right colon, anemia, and weight loss will be more. And there may be a mass felt in the right iliac fossa. That tumor mass you can feel in the right iliac fossa. Transverse colon tumor is rare. Transverse colon tumor is rare. But sometimes if it is present, it may be mistaken for carcinoma stomach. So we will have to differentiate it, because it is situated in the both are situated in the epigastrium. So we may take it for carcinoma stomach, though it is rare. Left colon cancer is more common. Usually it is stenosing type, that it is the descending colon may become stenosed. Its lumen becomes narrow. So it is present with increasing obstruction. So more and more stenosed, more and more obstruction. There will be pain in the left iliac fossa, altered bowel habits, increasing constipation. These will be the common symptoms. Naturally, the patient will tell, first I was taking 2 TSF of laxatives, I was okay. But nowadays, I have to take 4 teaspoons of laxatives. So things like that, increasing dose of laxative. Alternate with periods of diarrhea, means constipation and diarrhea alternate. palpable lump may be there, bleeding per rectum may be there, and sometimes with acute large gut obstruction. So sometimes obstruction will be acute. In the beginning, stenosing type, it is only constipation that may become chronic. But later on, sometimes acute obstruction may also occur. So acute obstruction is one of the features of left colon cancer. Sigmoid colon, constipation, blood and mucus in stools, colicky pain in the suprapubic area, and tenesmus. Tenesmus means it is also a type of pain while going for passing stool. There will be pain, and after a bit effort, some mucus and blood will pass through the anus. Early morning spurious diarrhea. This is one of the typical feature of cancer colon. In the morning, spurious diarrhea is there. Actually, this is not actual diarrhea. This is spurious diarrhea. Only some mucus will come out. There will be no fecal matter. There will be no fluid coming from above. It will be only mucus from the lower colon. So it is known as early morning spurious diarrhea. Left colonic lesion, lump, firm or hard retroperitoneal indentation possible. If you feel it, you may indent the lump. Mobile if sigmoid colon mass. If the tumor is in the sigmoid colon, it may be mobile in both the directions, vertical as well as transverse direction. But if it is affecting other parts of the colon, the mobility is very less or usually not mobile. Right iliac fossa mass, it may be hard, fixed mass. There will be no features of obstruction. Retroperitoneal mass may have liver secondaries and may have ascites. So these features on examination, you will have to exclude all these features. You know how to differentiate between extraperitoneal, intraperitoneal, and retroperitoneal mass. So by same test, we can know. Investigation later on, by investigation we will confirm it, but clinically we will know whether it is intraperitoneal, extraperitoneal, or retroperitoneal. Okay. Now come to the investigations. First we will go for a stool test. So always, most of the students forget when they are asked about the investigations, they jump on the radiological investigations first, CT and this, all the MRI and these things. Come for the basic things first. Stool examination, urine examination, blood examinations, which are available everywhere and cheap. So first you will have to see whether in the particular case, these examination will help you or not. So in this case, carcinoma of the colon, stool for occult blood is must. Because patient may not tell you about when the patient comes with the complaint of fatigue, weakness, breathlessness, and you are finding anemia, then you are asking, what is the color of the stool? Patient will tell it is normal color. Are you passing blood? No, sir, I am not passing blood. Then what will you do? You will have to send the stool, because if there are two types of bleeding. One is occult bleeding, which is not seen by naked eyes, or these are microscopic bleeding. And another is, this is also known as, occult blood is also known as concealed bleeding. So it is concealed type of thing, which you cannot see. And one is, which you can see it, or macroscopic bleeding. Okay. Then the color is also changed. The patient may tell, yes, blood is coming, or there is blackish stool, tarry stool type of thing. So that is, but Even if the color is normal, blood may be present and may be the cause of anemia, which you will further investigate, then you will find there is carcinoma of the right colon. Sigmoidoscopy may be there, or if it is high up, you can go for colonoscopy. Colonoscopy is the golden investigation because here you can see also and you can take the sample of the suspicious area for biopsy also. So that is the main thing still today. Then barium enema. Irregular persistent filling defect, apple core deformity. These two things are present if you take the X-ray, barium enema X-ray. Barium sulfate liquid or solution, barium sulfate solution is given by enema into the rectum and the colon. And after some time, you take the plain X-ray. So in the plain X-ray, if you find irregular persistent filling defect anywhere in the colon, that may arouse suspicion. It is not 100% confirmatory. Or you may find apple core deformity. This is for barium enema. Nowadays, it has been discarded because colonoscopy is the best thing. So we are rarely doing barium enema. Then serum CEA levels. Naturally, the tumor marker, and we go for its level, whether it is increased or not. CEA, in fact, it does not help in diagnosis, but it helps in follow-up. So that primarily, if you have taken the CEA and recorded it, and later on by other investigations, you confirm that it is a case of carcinoma colon, and then you manage it. After management, in the course of management, after 1 month, after 6 weeks, you do CEA again and see whether it is coming down or not. If it is coming down, that means your treatment is helpful. The patient is getting benefit by your treatment. Then comes the radiological examination, ultrasound of the abdomen. In ultrasound, you can see secondaries in the liver, or you can find ascites, that is a symbol of liver failure, hepatic failure. Okay. Then, but you are seeing here in ultrasound, you are not finding the carcinoma of the colon. Here, you may not get any indication of that. But CT scan, this may be helpful if the lesions or if the tumor spelling is wrong, LE, not I, omit I. So CT scan is helpful only for large tumors, large lesions. Okay. So you are seeing how much handicapped we are with all these modern tools also. So still the colonoscopy and taking the specimen for biopsy is the method of investigation. Treatment is surgery, but it depends upon whether the tumor is operable or not operable. So what are the signs of inoperability? It may come, all these everywhere you can see many points are there which may come in your MCQ questions as MCQ also, multi-choice questions also. So signs of inoperability you are seeing if the tumor is fixed or there is left supraclavicular nodes enlarged, there is ascites, presence of jaundice, liver secondaries, peritoneal and pelvic deposits found on X-rays and ultrasounds, then these are the signs where you cannot go for surgery to treat the carcinoma. What we do actually when we go for treatment, because when we go for treatment, it is known as curative treatment. Curative treatment does not mean the cancer has been cured. It only there are two terms. One is curative treatment, another is palliative treatment. Curative treatment, if stage is early stages of the cancer, in any place, not only in the carcinoma colon, any cancer, we go for radical only when there is chance of increasing the lifespan of the patient. If by our treatment lifespan is, that is, quantity of the life and quality of the life, both are increased, then that is known as curative treatment. That means 5 years survival, as we are seeing in cancers, should be there. So if it increases 5 years survival, then we go for curative. And what is palliative treatment? When it becomes inoperable, when there are distant metastases, then we cannot increase the lifespan of the patient. It is our limit. We are handicapped. We cannot do it. So patient will have to die. But what we can do, at least we can minimize the suffering of the patient while dying. And that treatment, which increases the quality of the life, not the quantity, quality of the life, is known as palliative treatment. Okay? Like for this, if there is absolute or total obstruction of the colon, what we can do? We can do colostomy of the proximal colon. Or even if majority of the colon is affected, we can go for ileostomy, so that at least the feces and the fluid is coming out and gases are coming out through some opening, and patient will be not so much traumatized by obstruction, pain, vomiting, etc. But the life of the patient will not be increased. The patient will die in its own course. So this palliative treatment and curative treatment, that is the difference. Here radical colectomy means removal of colon along with draining lymph nodes. So not only the colon containing the tumor, but also the draining lymph nodes are also removed at the same time. That is known as radical colectomy. The treatment will depend on the location of the primary tumor. Where the primary tumor is located, that also will change the mode of treatment, mode of operation. Like carcinoma involving cecum and ascending colon, we will do radical right hemicholectomy. Right means you have already known cecum, ascending colon, hepatic flexure, and proximal 2/3 of the transverse colon. These parts will be removed. That is known as right hemicolectomy, along with the lymph nodes. So it is radical. Transverse colon affected, then extended right hemicolectomy. That means all the parts I have told you, cecum, ascending colon, hepatic flexure, and right 2/3 of the transverse colon will be removed, along with left 1/3 and the splenic flexion. Both will be, that is known as extended right hemicolectomy. Then come to the colon, radical left hemicolectomy if descending colon is affected. In descending colon, we will have to left colon, or you already know, the distal 1/3 of the transverse colon, the splenic flexure, the descending colon, and the sigmoid colon. All these things will be removed along with the draining lymph nodes. That is radical left hemicolectomy. Okay, if sigmoid colon is involved, only sigmoid colon is involved, then we do sigmoid colectomy. Then we don't have to take out the descending colon and the splenic flexure, etc. Only sigmoid colectomy would do. So here you can see it. This is the right hemicholectomy. This is extended right hemicholectomy. You are seeing it. All this part up to this, we are removing it. This is left hemicholectomy. 1/3, this part, whole of sigmoid colon. Inoperable carcinoma. That is what we should do. If the tumor is inoperable, we cannot go for curative treatment, then we will have to go for palliative treatment. And what is the palliative treatment? It is the bypass, so that the stool and the gas and the liquid will come out. If it is on the right side, iliotransverse anastomosis we can do. So we will leave the tumor as such, we will not remove that, but the part, ileum and the transverse colon. Where the transverse colon? Before the tumor. Before the tumor. If tumor is on the left side, we will take the transverse colon and anastomose with ileum. What is our purpose of the bypass? Purpose of the bypass is to bypass the tumor. So how would you, because the tumor is causing obstruction, so the feces is not going beyond that. So we will have to bypass not before but after the obstruction. After the obstruction, we will anastomose. So it is, if it is on the right side, right colon. Then with the transverse colon, after the obstruction, we will anastomose transverse colon along with ileum. So iliotransverse anastomosis. If sigmoid colon is affected, then we will go for pelvic colostomy. The pelvic colon, we will have to take it out through separate opening in the abdominal wall. So pelvic colostomy we will have to do. Okay, you can avoid this one, not much important. Adjuvant therapy. As you know, there are two types of therapy, adjuvant therapy and neoadjuvant therapy. What is this adjuvant and neoadjuvant? Adjuvant therapy, sorry, time is so much, this is the last. Adjuvant therapy means if after the surgery, sometimes there is chance of leaving a few cancer cells in the body. We have not taken it out by accident or unknowingly. We are not knowing up to where the extension of the cancer is. So if some part is left there, cancer cells, then we go for adjuvant therapy so that those cells which have been left there, they are killed by this therapy. You are seeing here what treatment usually we do for adjuvant therapy. This is always done after the surgery. When we do the surgery, then we give this treatment. Apart from that, neoadjuvant means if we give before the surgery, but here that is not the point. Here it is after the surgery. So we use 5-FU along with folinic acid, or we use 5-FU along with levamisole. How much? For 6 months. So we think that this adjuvant therapy will help in killing if perchance we have left any cancer cells in the body. So this is our way of treating the things. So no, already time is so much. I went beyond my time. Thank you all for participating in this. This games is a very good platform, and you must take advantage of this. And the persons who are associated with this, I will be thankful to them that they are doing a great job for all of you and me too, because we are getting different topics, and at the same time, the latest information. Someone also asked about latest in surgery. We have nothing latest. Only we do either open surgery or we do laparoscopic. The results are same. Nothing is better than anyone. So both we can go. And as far as medicine is concerned, immunotherapy is the recent thing which has come, but it is not. It is still in the trial stage. So immunotherapy, if it will come, I think it will be a revolution in the field of treatment. So thank you all once more, and good night. See you again.
Thank you so much, sir, for giving your valuable time. We really appreciate that. And sir, I think we all have a very great and wonderful session ahead. And we are looking forward to do more such sessions with you, sir.
Okay, thank you. Thank you once again.
I want to say something.
Yes, any question?
No question, sir. Sir, I am the national president of Games Nepal.
Oh, hi.
Sir, thank you so much, sir. It's our privilege moment for have you in this platform, sir. Half of us are the age group of half of your teaching experience, sir. So it's a glad moment for us. Thank you so much, sir.
Okay, thank you, Mr. Ji. Thank you. Keep it up and go with it. This is a very good thing you have taken up, and continue with it and try to develop more and more with it. Okay. Sometimes again we will meet.
Sure. Yes.
Okay. Thank you once again. Good night. Good night.
Good night.
Thank you, sir. Good night.
Good night.
Thank you, all the participants. Good night.